Good afternoon, guys. This afternoon we're going to be focusing on the hip exam. Again, no exam is complete without asking the patient to fully expose the area of complaint, in this case the hip. We start off with the patient standing. We can assess a lot by the patient standing, just checking for obvious deformities, and following that we ask the patient to walk. There's a couple of abnormal gaits that we can look for. Antalgic gait, so the patient's got a painful hip, he might have a limp, he could have a one leg shorter than the other, so you get a short leg gait, or you could have a Trendelenburg gait. Another thing we can do with a patient standing is a Trendelenburg test. So I'm going to illustrate for you, if you can face the wall this way. Okay, looking at the patient from behind, we ask the patient to flex his one leg, thereby placing most of his weight on the other leg. In this test, if, for example, this was a painful hip, the right leg, this, if you can look at this line of the pants he's wearing, this hip would drop, indicating that being the pathological side. And then again, you compare it to the other side, if you lift the other leg. Again, this patient, you can see that this hip is not dropping, it's actually lifting up, which means that the abductors on the side are normal, so this hip is normal. Yeah. After that, we ask the patient to lie down, and again, we move to the right-hand side of the patient. Okay, in orthopedics, basic exam is look, feel and move. So to start off, we're going to look. Just expose the joint. You look at all your bony prominences, including your anterior superior iliac spine. You look in the groin, are there any scars, obvious deformities, masses, any color changes, atrophy of the muscle groups. After we've looked, we're going to now feel. Again, feeling over the bony prominences. If you go to comparing normal and abnormal sides, feeling over the greater trochanter, any tenderness there could indicate a bursitis that the patient might have. You also palpate in the groin. To locate the femur head, one feels for the pubic symphysis, your anterior iliac spine, and it's generally in a line bisecting it. You feel in the groin, is there any tenderness there? Patients with osteoarthritis could have pain there as well. Very important thing to do with a patient lying down is assess his leg length. What one can do is, by placing the legs together, make sure that your pelvis is not tilted, because that can give you an apparent leg length discrepancy. So you just feel the anterior superior iliac spines and make sure the legs are straight. And then what you can do is take a tape measure starting at your anterior superior iliac spine proximally, pull it down to the medial joint line, once at the medial joint line, down to the tip of the medial malleolus, and do the same for the other side and compare. If one doesn't have a tape measure handy, a simple test, just place the feet next to each other, look at the heels, and see if there's any leg length discrepancy. If one does encounter leg length discrepancy, one is not sure if the leg length discrepancy occurs in the lower part of the leg or in the upper leg. And the test we do to exclude this is called the Galeazzi test. So we take the patient, we place his legs in 90 degrees of flexion, and standing at the side, we have a look at the legs. And one can see by the level that the knees are, and comparing them, where the shortening is in the leg. Once one has concluded that the shortening might be in the upper leg, we now need to decide, is it in the femur itself or does the pathology occur in the hip? And a test we do there is called Bryant's triangle. I'm just going to use a patella hammer to illustrate this. One feels it for the anterior superior iliac spine, which I've located right there, and just to take in your mind an imaginary line perpendicular to that, and then one palpates on the side of the hip for the tip of the greater trochanter. And then you can see that there's a distance created between this line and the tip of the greater trochanter, and you do the same on the other side. And any difference there would indicate if there's a pathology in the hip. Okay, moving on, we're going to move to moving the leg now. We ask the patient to flex the hip as much as he can. Normally this should go to about 130 degrees. Okay, this is active movement. The difference between active and passive. Active is what the patient can elicit and do himself, and passive is what I can do for him. So now we check. The patient's got a good range of motion and flexion. Then we're going to do, while we're in this position with the hip at 90 degrees and the knee at 90 degrees, we're going to check for internal rotation of the hip. Do not be confused by the fact that the lower leg is moving externally. Just focus on what is happening at the hip. If one has to take an imaginary marker and place it on the femur here, as I move the leg like this, you can see it's moving internally. And this patient's got very good range of motion. It's almost 40 degrees. And then we do the opposite and check external rotation. It should be a bit more. In this case it is. You can either now test abduction and adduction in this position, by by moving the leg in abduction and then in adduction. Or alternatively, you can place the leg straight. And then what I do is just to feel the pelvis to make sure it is not coming with you. Because if patients who have contractures or stiff hips, by abducting their hip, the pelvis could move with you. And you can keep going with the pelvis going, and you can actually get a false impression. So just make sure that the pelvis is stable. Checking abduction. And then by crossing over to the other side, it should be a little less. Check for adduction. Okay. Then another test that you can do to exclude any flexion contractions is called the Thomas test. And what you do in the Thomas test is you have to exclude pelvic obliquity. Okay, now we've mentioned flexion contractures in the hip. A test to do to exclude flexion contractures is called the Thomas test. And what one does with the Thomas test, you place your hand under the arch of his back and you take the leg, the opposite side of the hip you're testing. And you flex the hip as much as you can. And by doing this, you eliminate the arch of his back or the lordosis in his spine. You can feel it because his back pushes against your hand. In this position, you have then eliminated the pelvic obliquity, and then you look at the opposite hip to see if anything moves that side. In patients with flexion contractures, when you push on this side, this leg will slightly rise off the bed, and depending on how much, you measure those degrees, and that's the degrees of flexion contraction that he has. And then you do the same for the other side. Other tests we do is called the Faber test. It's an acronym, F-A-B-E-R. The F stands for flexion, so you flex the hip. The A and B stand for abduction, so you abduct the hip, and the E and the R for external rotation. Or a simple way is to put the leg into a figure of 4. This test is basically just to eliminate the cause of the pain. So some patients will come in complaining of hip pain, but it's actually pain originating in the back. And what the Faber test does is it localizes the pain either to the groin and you know it's hip pain, or to the lower back and you know it's sacroiliac pain. Another test we can do for impingement is called the Fader test, which is F-A-D-I-R. So again, F is for flexion, the A-D is for adduction, and the I-R is for internal rotation. And by doing this, one can cause compression between the neck and the acetabulum if there is something to compress there. And this will elicit pain, and then you know the patient's got impingement. Lastly, what we do is we have to always check for neurovascular test in any exam. So check all your distal pulses, check your sensation in all your dermatomes from the hip down to the foot. And no big joint exam is complete without examining the back and the knee as well. Okay, we're going to move on to the knee exam now. Very importantly, always get your patient to undress fully so you can see everything, he's going to not miss anything. Once you can fully visualize the limb, you start off with the patient standing. Address the patient from the front, looking for obvious deformities, varus or valgus deformities, any bumps or lesions or effusion on the knee. Moving to the side, you can look at the patient the whole body, starting at the back, see if there's any lordosis, hip deformities, flexion or extension. Looking at the knees, is there recurvatum or procurvatum? And then moving to the back, you can also see obvious lumps or deformities, example, Baker cyst. Once you've done looking, you can ask the patient to walk. There's a couple of obvious things you can look for in the gait. Patient with painful legs, Ventalgic gait, they can have a short leg gait or a Trendelenburg gait. Once you've visualized the patient walking from front and the back, you then ask him to move to the bed. Patient will lie supine on his back. Always approach the patient from his right hand side and generally your dominant right hand. I always approach the patient from the patient as a whole. It's not just the knee, the patient has a complaint, but he is still a patient as a whole. And then once you've looked at everything regarding the patient, go to the specific pathology. So again, make sure you can visualize the entire joint. What I like to do is I work from the outside in, so we don't forget anything, and work anatomically. If you have a system and a structure, you won't forget anything. Okay, so looking at the leg, we start with the skin. What do we see on the skin? Any scars? Sometimes patients with acute trauma can come in. Are there any wounds? Is there bleeding? Color changes, erythema. Underneath the skin, we have soft tissue, so the subcutaneous tissues. So when I look there, it's for any swelling. Again, you can see if there's any Baker cysts or effusions. Following that, we assess for range of motion. So we ask the patient to flex the knee as far as he can, and then to extend the leg as far as he can. In this case, you can see there's a slight recurvatum. This is normal in a lot of patients, and especially in females or patients with ligament laxity. And always compare to the opposite side. And always remember to finish off your exam with a thorough neurovascular exam. With regards to effusion, we classify them as mild, moderate, or severe. In order to do this, you have to milk the fluid from the suprapatellar pouch into the knee. You will see that then the knee fills up, depending on the size of the effusion. If it's a mild effusion, and you try a patellar tap, you won't initiate any tap. A moderate tap, there's fluid between the patella and the femur, so it lifts it up, and just with your finger, you push on the patella like this, and you should hear a clunk, and you can also feel it. With a very severe effusion, there's so much fluid between the patella and the femur that when you try to initiate the patella tap, you won't feel anything. So that's a severe effusion. Then again, like I said, we move from the outside in. On the outside, we have your collateral ligaments. This is obviously lateral and medial. Now we have to stress them. The patient in your history would have elicited asking if there was any pain, for example. And now we're going to stress it. So for the lateral collateral, what you do is you give a varus stress, placing your hand on the femur, on the medial side of the knee, and putting a counter force with your other hand. Look at the patient, see if it elicits any pain, and also look for laxity. We grade our laxity. One, by doing this, there won't be any movement, but you'll have pain. Two, you'll see slight movement in the leg, but it has a definite end point. You can't go further than that point. That would be a grade 2. And in a grade 3, there's very obvious laxity. You'll see quite a large varus deformity when you push with the other hand. And for the medial collateral ligament, the same thing. Moving inside that, you've got on your lateral side here, if you palpate here, you feel a little nodules called Gerdy's tubercle. That's where your ITB inserts. You can also just feel if there's any tenderness. Patients with ITB or with bursitis might have pain there or swelling. Moving medial to that, in the center of your knee, you've also got an obvious nodule, that's your tibial tuberosity, and that's where your patellar tendon inserts. Especially in adolescents, they can have pain from an osgood schlatter, so always check that. And then medial to that is your pesa and serine bursa, and that's where your sartorius, gracilis, and semitendinosus insert. There's also a bursa underneath that that can be swollen and painful, so just see if you can elicit any tenderness there. Moving medial to that again, you have your menisci. Your menisci, to start with, you feel just for joint line tenderness. Firstly on the medial side, palpate, and again on the lateral side, again look at your patient and see if that elicits any pain. There are a couple of provocative tests that we can do to see if there's any meniscus pathology. One is called the McMurray's test, and the way I think about it is your menisci now sitting between your tibia and your femur. So I want to relieve all stress from the meniscus, and by doing, for example, on the medial meniscus, flex the knee, I put a valgus stress to open the joint space on that side, and externally rotate the lower leg, and then putting your finger on the joint line, you repeat the process in the opposite direction. And that compresses the meniscus between the tibia and the femur. And if that elicits any pain, or you can palpate a click, it's a positive McMurray's. And again, for the opposite side, I'll take you through. Place your thumb on the lateral joint line. Again, flex the knee, internally rotate, and put a varus stress on the knee to open up the joint line, and do the opposite movement. And again, feel for a click or see if there's any pain. Another test we can do, if I can ask you to stand quickly. It's quite an easy test that you can do for patients. This will be not the way in. It's called Thessaly's sign. For medial meniscus, you ask the patient to internally rotate his feet and then to crouch down. And that, if he elicits any pain on the medial side of his knee, could be positive for meniscus injury. And then externally rotating the feet and again crouching down gives a positive sign for the lateral meniscus. Okay, again. Okay, now moving inside from that now, we get your cruciates. It's the anterior cruciate, and that originates from the tibial plateau in the lateral direction to the femur, and your posterior cruciate, which goes in the medial direction. The anterior cruciate is important for anterior stability of the tibia in relation to the femur. So a test we can do is called the Lachman test, by placing the knee in 30 degrees of flexion and asking the patient to relax. You grab the tibia and you hold the femur, and then you shear them in relation to each other, And in a normal knee, there shouldn't be any movement. But if an ACL was off, you would get a definite shift. Same for the posterior cruciate. Another test we can do is called the anterior draw sign. And the anterior draw sign specifically for the anterior cruciate. You get the patient to bend his leg more or less 90 degrees, and you sit then on his foot so it doesn't slide. What I do is, placing my hands on the calf, you palpate his hamstring insertions with your index fingers. The reason being, you want to feel if there's any tension. A lot of patients with pain or apprehension will tense their hamstrings, which doesn't allow you to do the test. So feel first that there's no tension, ask the patients to relax, and warn them what you're going to do. And then I place the thumbs on the joint line just above the edge of the tibia. You see bone, and then you feel the joint line. And then you give a few sharp tugs. If the anterior cruciate was pathological, or if it was off, so to say, your tibia would shift forwards, like a draw. Another test to do for posterior cruciate, you get a posterior draw sign. First of all, to look, you must compare the normal leg with the painful leg. And what you do is by standing next to the patient and just crouching down and looking at the knees from the side. The patient with a posterior cruciate, and his job being to prevent posterior shear of the tibia in relation to the femur, one will see a definite sag or recurvatum, especially evident in thinner patients. Sometimes not always that obvious. One must beware when doing the draw sign. If a patient has a posterior cruciate ligament injury, the tibia would then fall back in relation to the femur. And when one tries to do the anterior draw sign, all you're doing is bringing the tibia back to its normal position. And one might confuse this for a positive anterior draw sign, when in actual fact the posterior cruciate is off. So just be aware of that.
Now we're going to have a look at the foot and ankle examination. And once again, you want the patient to completely take off his shoes and his socks. And in the case of a patient wearing long trousers, you want that removed as well. So ideally you have a patient in his shorts so you can see at least up until the knee. Alright, so first of all you ask the patient just to walk and you assess his gait. Now you would look for the following things. You would look for an adequate heel strike and adequate toe off at the end of the stance phase. So thereafter you'd have the patient standing still. You'd assess him from the back. Just turn so the camera can see. You'd assess him from the back, especially looking at his heels. See whether both feet are plantigrade. What we mean with a plantigrade foot is a foot that is that can at least have 90 degrees dorsiflexion and is essentially flat when the patient is standing. Thereafter you can look for any valgus or varus deformities of the feet. So then we have a look at the feet from anterior. Now what one can observe, especially in this patient, there's a previous surgical scar on his left foot. You'd also have a look at the MP joints of the big toes, and you'd look whether there's any signs of a bunion. Once again, you'd look at the medial arches of the foot, and you'd assess whether it's a flat foot, whether it's a calvus foot, in other words, a high arch, or just a normal foot. When looking at these feet, one would probably say there might be a certain degree of a flat foot. But without going into detail about that, we'd proceed and ask the patient to sit on the bed with his feet hanging down the side. So next up we want to palpate, and it's important to realize that in palpating we will start off with the ankle joint. In palpating the ankle joint, the whole of the fibula is essentially part of the ankle joint. So start palpating the proximal fibula and assess for any pain or any localized tenderness. Thereafter you'd squeeze the tibia and the fibula together, and should the patient have acute pain over his ankle joint, that can be indicative of a distal tib fib joint sprain, what we would call a syndesmotic injury. Thereafter you'd proceed to palpate the lateral malleolus, situated over there. Posterior to the lateral malleolus, you can palpate your peroneal tendons. Working your way around laterally, you can feel for any tenderness over the anterior talofibular ligament, and then also the posterior side, and as well as the talocalcaneal ligament. Thereafter, you'd go ahead and palpate the midfoot for any tenderness, any deformities, and then you can also palpate your metatarsal joints individually. Especially taking care to have a look at the big toes metatarsal joint, as one frequently encounters pathology there. Working your way around to the medial side, I'll demonstrate on this ankle. You'd typically palpate the deltoid ligament as well as the medial malleolus. Posteriorly, important to palpate there is the posterior pulse, and then you have your flexor hallucis longus, the posterior, and your flexor digitorum running at the back of your medial malleolus. Whilst we were looking at the pulses, one would also palpate on the dorsum of the foot his dorsalis pedis pulse. Next up, you're going to assess the movement. Movement we assess active and passively. So active range of movement will be where the patient himself, you ask the patient to dorsiflex the foot, and then you ask the patient to plantarflex the foot. Thereafter, you can ask the patient to invert and evert the foot, and the movements can then be repeated by yourself to see whether you can get any increase in range of motion. As far as the ankle joint is concerned, we do have a drawer test, which is conducted in a similar way to the knee, where one looks for any anterior or posterior translation of the ankle joint, which can be indicative of ankle ligamentous injuries. The drawer test is performed like this, where you, with your one foot, grasp the heel, with the other foot stabilize the tibia, and then look for any anterior or posterior translation. Right, then we ask the patient to lie prone on the bed. Can I ask you just to, for illustration purposes, just to have your feet going off on this side. Just lie on your stomach. And move downwards a little bit. Okay, in this position, we want to assess your tendo Achilles, and this is called the Thompson's test, where you would typically squeeze the calf, and by squeezing the calf, you get plantar flexion of the foot, which means the whole your tendo Achilles is intact, and you typically compare it to the other side to see that they are equal. And that more or less concludes your foot and ankle examination.